Hi there, my name is Asad. I'm a fourth year medical student. Let's review some of the cases for the lab on inflammation. Case number 1. A 12-year-old boy presents to the emergency room with acute right lower quadrant abdominal pain associated with nausea and vomiting. The pain started 6 hours ago in the periumbilical area but quickly localized in the right lower quadrant. On physical examination, his temperature was 102 Fahrenheit, pulse 100 per minute and regular, respiration 20 per minute, blood pressure was 100/70. The rest of the physical exam was negative except for guarding and rebound tenderness in the right lower quadrant. CBC revealed a white blood cell count of 18,000 with 70% neutrophils, 12% bands, and 18% lymphocytes. Okay, so what are the most important parts of this case? This patient has periumbilical pain that moves to the right lower quadrant. He also has guarding, rebound tenderness, elevated white blood cell count, and fever. Can you guess the diagnosis? It is acute appendicitis. And how is this patient managed? Basically, he will go to surgery for an appendectomy.
Okay, so this is a normal appendix. And here you have the mesoappendix, which is a fatty tissue connected to the appendix. And it doesn't look inflamed, doesn't look too red. This is normal. Okay, so the first thing to notice is that the appendix is actually just this area right here. And then attached to the appendix is some fat called the mesoappendix. But what you notice is that the whole thing appears red and inflamed. And these white portions right here, these are the exudates. This is a normal cross-section of an appendix, and what you notice is that the mucosa layer is all intact, and you notice that it kind of forms wavy lines. These are the glands, and these right here, these are the lymphoid tissue, aka the Peyer's patches. And then also notice that this is the muscular wall, and whenever there's a perforation, it'll completely go through that. Alright, what we have here is a low power microscopic appearance of the appendix, and what you can see is that here's the intact mucosal membrane, and these are the glands, but then all of a sudden they disappear right here. And that's the point, is that this is the ulceration, which is the sloughing off of that inner lining. Right here you have all the exudate. And then here you have the muscularis layer, which we pointed out before in the cross-sectional. And then right here is some of the fat from the mesoappendix. And then one last thing you'll notice right here is that this is the Peyer patch, the lymphoid tissue. This is a medium power view of the appendix, and the first thing you notice is that all of these cells right here, these are all neutrophils. It's signifying the inflammation. And then right here you have acute inflammation, and then right here you have the red areas. These are signifying vascular congestion. And then here you have some of the remaining glands and the lining of the mucous membrane. This is a high power view of the appendix, and really the main thing to appreciate here is that there are so many neutrophils everywhere. And the way you can sort of tell a neutrophil is this one right here, for example. It has a bilobed or even trilobed nucleus, so something like this. This is in contrast to lymphocytes, which generally just have their nucleus is not lobed, it's just one nucleus. This is a peripheral blood smear, and the main thing to see here are the neutrophils. And again, you can see they have many lobes to their nucleus. And these right here are red blood cells scattered everywhere. And these small, kind of dark purple dots, these are all platelets.
Case number 2. An 83-year-old woman was transferred from a nursing home to an acute care facility because of a history of fever, chills, and productive cough for 2 days. Physical examination revealed temperature of 103, pulse 110 per minute, regular, respiration 24 per minute. Chest exam revealed Ralls in the right lung base. Chest x-ray showed a right lower lobe infiltrate. Sputum culture grew Streptococcus pneumoniae. What are the key points in this case? 83-year-old female, fever, chills, productive cough. Physical exam shows Ralls in the right lung base. Chest x-ray shows right lower lobe infiltrate. Sputum culture grows Streptococcus pneumoniae. What is the diagnosis? This is an acute bacterial pneumonia.
This is a gross appearance of a lung, and right here you'll notice the area of consolidation. And then here you'll notice the normal lung. It's kind of a dark brown area. This is all normal. This is a normal cross section of a lung, and what you see are the lining of the alveoli that have pneumocytes and blood vessels, and in the center you notice that it's clear, and that's because that's where the gas exchange occurs. This is a low power appearance of the lung, and the main thing here just to point out is the clear demarcation between normal lung on the right, and this is on the left is the pathological lung, which has a bunch of consolidation that we'll see better on a high power view next. Here we have the outline of the alveoli, but now instead of a clear center, it's filled with a bunch of inflammatory cells. This is a high power image of the alveoli, the outline which is right here. And you'll notice in the center we have a lot of inflammatory cells. We have macrophages right here. And one thing to notice about these macrophages is that they have a prominent nucleus, but there's also quite a bit of cytoplasm there. And this is in contrast to, we have neutrophils here, which have sort of a, again, a bilobed or trilobed nucleus. And then here you can see red blood cells in the alveolar capillaries.
Case number 3. A 42-year-old woman underwent hysterectomy because of pelvic pain and irregular menstrual cycles associated with heavy menstrual bleeding. She also complained of an intermittent, whitish, mucoid vaginal discharge between periods for several months. So what is the diagnosis here? It is chronic cervicitis, and there are a few things that can cause this chronic irritation. First is yeast candida, second is trichomonas, third is Gardnerella, fourth is chlamydia, or Neisseria gonorrhoeae.
This is a gross appearance of the cervix, and right here is the endometrial cavity. And on the outside here you see the ectocervix, which is all red and inflamed. This is a microscopic appearance of the ectocervix, and right here is the basal layer. And as the cells move upwards from the basal layer, you'll see that the squamous cells get flatter in appearance, so that at the top here you just have a flat layer of squamous cells. This is a low power view of the cervix, and here you see the basal layer right here. And again, as the cells go from the bottom to the top, you see they form the squamous epithelium. But all throughout here, the main change is that you see a bunch of inflammatory cells and red blood cells. This is a high-powered image of the cervix, and right here you notice we have a endocervical mucus gland. And then we have signs of inflammation. We have dilated blood vessels right here. Then we have a plasma cell right here and a lymphocyte right here. This is a high-powered view of the endocervical gland, and the main concept we're going to point out here is metaplasia, which is when you have a cell change from one type to another due to some kind of irritation. So right here you have the columnar epithelium, and it has gone a change to a squamous epithelium. And all around here, everywhere on the outside, you see chronic inflammatory cells.
Case number 4. A 30-year-old African-American female presents to her physician's office with a history of dyspnea and dry cough for 6 months, as well as low-grade fever and night sweats. Physical examination reveals a temperature of 100.4 Fahrenheit, pulse 80 per minute, regular, respiration 18 per minute, and a blood pressure of 120/75. Bilateral, non-tender cervical lymphadenopathy was noted. Chest X-ray revealed prominent bilateral hilar lymphadenopathy. CBC revealed eosinophilia. Serum calcium was 11. A cervical node biopsy was done. Culture of the node was negative. What are the key points of this case? Female, age 30, dyspnea and dry cough, fever, cervical lymphadenopathy. On chest X-ray, there's hilar lymphadenopathy, elevated calcium. What is the diagnosis here? This is sarcoidosis, which is an inflammatory disease that affects the lungs and is seen mainly in women between the ages of 20 and 50. The two main reasons why this is sarcoidosis and not tuberculosis is that 1, the culture was negative, and 2, under the microscope we were able to see that the granulomas were non-caseating, whereas with tuberculosis they would be caseating.
This is a low power view of a normal lymph node, and here on the outside you see several lymph node follicles. This is a high power view of those lymphocyte follicles, and here on the outside you see that we have a bunch of small lymphocytes, and on the inside we have a mixture of both lymphocytes and histiocytes. Alright, this is a low-powered microscopic image of the lymph node of this patient that we're talking about right now. And based on the previous architecture that we saw before, you can see here are some lymphoid follicles, and surrounding them are some lymphocytes. But here, the architecture is interrupted by these lightish areas that are granulomas. And we'll be seeing in the next few slides some more high-powered images so we can look at these granulomas. This is a medium-powered image of the lymph node, and here we have the granuloma. Outside of the granuloma we have the lymphocytes. Now let's talk about what we see on the inside of the granuloma. Right here we have the lymphocytes. Right next to it there is an epithelioid cell. And then right here is the multinucleated giant cell. And the idea here is that with the granuloma, the body's trying to kind of wall off the antigen. This is a high-powered image of the granuloma, and we can see very clearly the epithelioid cells. You notice they have a flat architecture. Here we have lymphocytes. Here's a multinucleated giant cell. And most importantly, you want to notice that there's no necrosis. That's what separates sarcoidosis from tuberculosis.
Case number 5. For this case, there won't be a vignette, but let's discuss ulcerative colitis. This is one type of inflammatory bowel disease that can cause patients to have abdominal pain, bloody diarrhea, and tenesmus. It is diagnosed with a biopsy of the colon or rectum.
This is a gross appearance of a normal colon, and you notice that there's no swelling, no erythema. You have normal folds here. This is a very healthy colon. This is a colon that has a lot of inflammation going on. All these, the black area, the red areas, this is all signifying inflammation. This is an image of a normal colon, which I want to review before we go on to the pathologic image. And here you can see the lining of the colon. And here are the mucous glands. And inside the mucous glands you see the goblet cells. And right down here you have a Peyer's patch. So here you see the normal lining of the colon, and then all of a sudden right here it ends, and this is where the ulcer begins. And right here you see some dilated red blood vessels. This is a close-up image of the ulcerated region we were looking at, and here at the top you see the exudate. Here you see several dilated red blood vessels, and right here you see some inflammatory cells. This is another high-powered image showing inflammatory cells, dilated red blood vessels, and here are fibroblasts.